So for the next section, we're going to be talking about fractures, bones breaking in somebody's body. So types of fractures, we've got a few different types that we need to know about to classify these things when we start to see them. So one is an open fracture. That means that the part of the bone that's broken has protruded outside of the body and the skin is open, which is where the name comes from. Opposed to that is a closed fracture, where we have our broken bone, but it remains inside intact skin, so it's inside the body. That'd be our closed fracture. Next is displaced. This is where the two broken ends, they're no longer kind of pointed in the same direction or anatomically aligned. They're not aligned, so the fracture is displaced. The bone is displaced relative to itself. And then there's a non-displaced fracture. So this is a fracture where the bone stays in its anatomical position, but we have a fracture of the bone material. Lots of different ways that bone fractures can occur, or etiologies, or like presentations really, on how they can occur. So transverse, going across, linear, going the length of a bone, non-displaced or oblique, which is going diagonal, and non-displaced we've talked about. Spiral fractures are the result of twisting of the bone. We actually tend to see this quite a bit in children where there's a suspected abuse situation, because it's like if parents grab a kid by the arm and the kid kind of twists, this is the kind of fracture that may occur. So high suspicion of abuse with spiral fractures. Green stick fractures, which are where the bone breaks, but we usually, and we see it just kind of on the edge, it looks kind of like a linear fracture. But this one is primarily reserved for children because their bones are still kind of rubbery from development and growth, that they can kind of bend much like a green stick or like an immature tree branch. You just kind of bend it and it fractures a little bit, but it doesn't break completely. And then comminuted, this is like a shattering of the bone. Now is this kind of fracture. So for our assessment behaviors, the things that we're looking for as a nurse when we take care of these types of patients, first is pain. There's often quite a bit of pain that patients experience when they have a bone fracture, particularly if it's an open fracture, so if it's broken through the skin. Physical deformity, so we want to look for that physical deformity and take note of how deformed the extremity is, that sort of thing, and range of motion limitation. With that also comes circulatory limitation, and we'll talk more about that in just a minute. Those are kind of the big things. We want to become experts in that deformity that that patient has and how it's impacting their normal movement. A couple things that we need to pay attention to very, very closely. One is palpation of pulses distal to the fracture. So if somebody breaks their wrist, we want to make sure that downstream of that fracture, we can still palpate their pulse, meaning that their CMS check is intact. Because one of the big complications with any type of fracture is that we can actually have a kind of pinching or severing of arterial blood flow distal to that fracture. So we always, always, always want to work our way kind of up the arm and make sure that there's circulation to the entire extremity. If it's a broken arm or if it's a leg, we'll start with our dorsal, then go to popliteal and possibly up to femoral, just to make sure all of our pulses are strong, but especially the ones that are distal to the fracture. The other big thing we want to look out for is people going crazy. All right, always want to look out for that. But with fractures in particular, there's several reasons why they could start to have an altered mental status. And we're going to talk about some of those specific reasons in just a second. But pain can absolutely be a reason that patients start to become goofy. Also, internal bleeding. If patients become hypovolemic, they're going to have a low blood pressure, meaning their brain isn't going to be perfused with blood the way it should be, so they start getting goofy. So we always want to pay attention to alterations in mental status as well. For the medical diagnosis, we're looking at x-rays. It's a way that we can do a study on a patient to visualize density in the body. So here we can see this is like a green stick fracture. See, the bone hasn't really broken, but it's kind of just filleted open like that. So that's a green stick fracture in a child. And here's like a spiral fracture in an adult. Yeah, so we're looking to visualize the fracture. That's kind of, I can't really say it any more complicated than that. We just want to know where it is. So nursing diagnoses that we want to pay attention to when we're caring for this type of patient. One, acute pain, right? We can predict that both of these people are having some pain associated with that injury. Other is impaired tissue perfusion. So this is getting back to that, making sure that they have distal circulation from their fracture, and that fracture, especially with closed fractures, and open fractures also, take it back, with all fractures, we want to make sure they have distal circulation. There hasn't been any kind of internal tissue damage associated with that fracture. Impaired physical mobility, absolutely. Somebody breaks their leg, their hip, they're not going to be moving around as well as they could. And disturbed body image, both in terms of the acute injury. Now, if somebody's arm is bent the wrong direction, they're definitely going to have a disturbed body image, but also with recovery. As those bones heal, there might be some limitation in movement or alteration in their physical appearance. So we do want to be aware that that could be a psychosocial component to their fractured extremity. So for the medical plan, for medical management, so we're talking about internal medicine or like medical doctors, not surgeons, symptom control is the big thing. We want to stratify our pain medications, meaning that we don't just want to go all in on the strongest narcotic we have available. We want to use a combination of medications because we always want to treat the patient's pain most effectively with the least amount or least severe medication possible. So this could mean that we alternate a pain regimen schedule, meaning we're alternating IV versus oral medications or narcotics with something like an NSAID, so that we're stratifying how that patient's getting pain relief. Also, prophylactic antibiotics could be a thing. We definitely tend to see prophylactic antibiotics used for patients who have an open fracture, so that bone is protruded out of the skin. And then prevention of complications. So impairment of CMS, circulation, motion, sensation, always, 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 as long as we have that acute inflammation going on from a fracture, we want to make sure that downstream they still have good circulation and that we're not seeing any neurologic deficits with their motion or sensation. Pulmonary embolism can also be a complication. Anytime the body is launching an immune response, forming clots, there's a risk that those clots could start to travel around the body, landing in the lungs, which could be an issue. One other one that's particularly unique to bone fractures, especially long bone fractures or any place where bone marrow development happens, so like humerus, femur, parts of the pelvis, we can get what's called a fat embolism. Because those long bones do have lipid molecules and kind of lipid storage that does take place inside the bone structure, when those bones break, some of that lipid content can enter circulation because it's no longer contained inside the bone. So fat embolisms, they mimic like a DVT or a PE as far as their presentation, but the etiology isn't a blood clot. It's actually from a piece of fat that has been released from inside the bone. So patients will present with chest pain, shortness of breath, which is the same as a PE, but there's one unique symptom to a fat emboli, which is this petechiae. So this is what it looks like. They'll see this petechiae on their chest, which tends to be more indicative of a fat emboli as opposed to like a pulmonary embolism. So that's one of those unique differentiating symptoms that you may see that can cue you in that the patient has a fat emboli. Also respiratory and neurologic impairment. So again, now we're getting back to symptoms that mimic like a clotting disorder, like a pulmonary embolism. So respiratory symptoms would mimic a PE, neurologic symptoms. If patients have a clot in one place in their body or an obstruction, we want to look out for the next place. So if we follow circulation from venous return, it's going to go through the right side of the heart to the lungs, which is where we get our pulmonary complications. If it keeps going past that, it goes to the left side of the heart and then out to the aorta, and the first branches off the aorta go to the brain, which is where we can get neurologic impairment. So symptoms that mimic a stroke are really what we're looking for here. Another big one is compartment syndrome. We're going to talk quite a bit more about this in just a little bit in this lecture, but compartment syndrome is one of those life-threatening emergencies that can be a complication of bone fractures. And then we want to prepare the patient for definitive treatment, whether that's a surgical repair or whether that's realigning the bone and casting in order to splint it so it can heal. But we want to prepare for however we're going to heal that bone. Surgical management takes into a couple different kind of phases. There's our preoperative phase where we do things like traction, which will both stabilize the fracture. It's kind of, so traction is just like pulling on something. So if I pull on my hand, I'm putting my arm in traction. So it'll stabilize a fracture. It also helps with symptom management. One of the complications that happens with a bone fracture, especially a displaced fracture where the bone's no longer aligned, is that the length of that extremity actually shortens because the bone isn't maintaining the normal anatomical length. With that shortening, if there's musculature around it, it causes those muscles to kind of freak out a little bit and they start spasming, which can be extremely painful. We see this quite a bit for patients who have a hip fracture. So now their leg is anatomically shorter than it was prior to their fracture, which can cause muscle spasms and is usually one of the main reasons that patients develop pain secondary to a hip fracture. And then definitive treatment is our ORIF, which is a fancy way, so the name is open reduction internal fixation. So this is a fancy way of saying cut them open, fix the bone, and then nail it shut. So that's kind of what that is. It's like the Home Depot of medicine. They're going to cut the person open, fix their bone, and then nail it in place so that it stays with the proper anatomical alignment. So for our nursing plan, one of the things we want to look out for, especially with hip fractures, is Buck's traction. So this is one of those pre-operative interventions. So this is what Buck's traction looks like. It's this it's applied to the lower extremity with a boot that's wrapped around the patient's calf, and then there's a string that's attached to a weight. And usually this weight is about 5 pounds, maybe 7 pounds, so it's not a lot of weight, but it's just enough to add some tension to the musculature in that extremity to reduce the likelihood of muscle spasms, which can cause pain, and assist with that alignment of the bone. So this is called Buck's traction. Super, super important when we have a patient who's in this type of traction is one, because we're wrapping this around their leg, we need to make sure we didn't wrap it too tight and cut off circulation of their foot. So CMS checks, absolutely a big deal. This little boot component is usually either hard plastic or metal. So anytime we put something hard against the skin and then we wrap it tightly onto the skin, there's a risk of tissue damage. So skin breakdown, always a concern with where we have that attachment device on our patient. Also pain management. The whole point of Buck's traction is to help reduce pain. So we do want to make sure that we're addressing that. And then integrity of the traction system. What that means is that in order for Buck's traction to be applied properly, this string with the weight cannot be obstructed in any way, meaning that we can't have any sheets or anything draping over the cord because that's going to change the amount of weight and also the direction of traction that's being applied to that patient. So these weights need to be hanging freely, not dangling against the side of the bed or trapped under the bed. They need to be hanging freely in the air. And the rope that's attaching the weight to the boot component can't have anything resting on it. So that whole system needs to be open and kind of free from obstruction in order to properly apply Buck's traction. And really important, like Buck's traction, nothing's attached to the bone. It's all a skin and superficial tissue type of traction. A more severe type of traction is our skeletal traction. This is where pins and wires are put through extremities, and then we apply these types of traction mechanisms to them. So this is like we see this most commonly with like shattered bones, where distally they're going to have a pin inserted. So the bone fracture would be kind of up here and there'd be a shattering of that bone. So they want to maintain anatomical length and alignment with what's no longer stable inside the patient. So these are patients who have very, very severe fractures. And we can use heavier weights because we're anchoring directly to the bone. But we don't see skeletal traction all that much. Definitely see Buck's traction much more frequently. So for an ORIF, so that surgical repair that our patient's going to go through, here's all the Home Depot kind of stuff, all the pins and screws and plates It looks like that section next to the lumber section where you get all the screws and all those weird shaped things to attach two pieces of wood together. So what we're going to be doing is reducing, which is realigning, and immobilizing the fracture. So getting anatomical alignment back and then stabilizing it with screws and plates so that it can't move around. The internal fixation is used with all this like gnarly stuff that goes inside patients' bodies, and they'll either live with this long-term or permanently. Sometimes the screws can be removed because they do cause other complications for patients long-term. Things like all the stuff that we already know is a problem for patients who have foreign bodies inside them long-term. So things like blood clots and infection are always a risk for people who have hardware in their body long-term. So they may or may not be removed long-term. One important thing to note is if patients have an ORIF done, anatomically when they come out of surgery, they are fixed. They're repaired because we put in hardware to fix the bone. But structurally, that bone is not secure. So we always want to check with our orders from the surgeon to make sure that a patient's weight-bearing status is appropriate for what we're trying to do with them. That meaning if we send a patient off to surgery for a broken hip, and they have an ORIF done, so they have a surgical repair of that bone in their hip, when they come back, we need to double check to make sure that they can bear weight on that extremity, or if we need to allow time where they can only, say, touch down, meaning they can just put their foot on the ground but not put weight on it, if there's a period of time that we need to do that. So always, always, always check your physician orders and your physical therapy recommendations for advancing a patient's weight-bearing status on any extremity where they've had an ORIF or some kind of hardware left in place from a bone fracture surgery. So for implementation, the things that we need to look out for, it's getting gnarly over there. CMS checks. Make sure that we don't have any impairment of circulation after that bone has been broken prior to surgery and also after surgery to make sure that that inflammatory process that's a part of normal bone healing hasn't blocked any arterial or distal blood flow. And then look out for compartment syndrome. So we're going to get into that next, and warning, it's going to get gross. We've got some gnarly pictures of compartment syndrome just to like drive home that that's a problem. Then mobility stuff, we want to make sure our patient is being mobile. Right? The longer a person sits immobile, the more likely they are to develop blood clots. And if they've got hardware in place, they're already at another risk factor for developing blood clots. So we want to get them mobile as soon as possible, but keeping in mind what's appropriate for the level of injury or the type of recovery they're having. So always check your physician and PT physical therapy orders. And then our neuro checks. So part of our CMS checks is our neuro checks, but don't forget also neurologically, making sure that their brain is intact. They haven't started getting goofy. So they're still ANO times 4, and there's no signs and symptoms of stroke. So that unilateral face presentation and weakness, that kind of stuff. So compartment syndrome. We've alluded to it a couple times. Let's get into it now. So compartment syndrome, first thing we have to remember from A&P, all the way back to A&P, is that the body likes to put things in a bag, right? Just like the lungs. We learned about the lung bag. We've learned about the heart bag now. Muscles are also in a bag, right? We call those bags compartments. So compartment syndrome is when there's an injury to a bone. Say this bone right here gets broken. There's going to be an inflammatory response because of that fracture. One of the things we want to look out for is that those bags don't like to expand. So as we get an inflammatory response or bleeding as a result of a bone fracture, the pressure inside these compartments can increase because it can't necessarily expand. As that pressure increases, it can do a couple things to the tissue inside the bag. One is that pressure will occlude blood flow distally. So we're going to not be able to circulate the rest of that extremity. The other is that increased pressure can cause pressure injury to those muscle tissues inside the bag. So this is a medical emergency because we are going to have impaired blood flow distal to the compartment syndrome and also pressure injury destroying tissues at the site of the compartment syndrome. So this is very, very severe. If left untreated, this will result in an amputation. The patient's going to have dead tissue from the level of injury distal. And the only solution to that level of necrotic tissue is full amputation. So the things we need to look out for is the neuromuscular damage is irreversible, impaired circulation, we've talked about that. So the things we need to look out for are always our CMS checks distal to any type of ORIF repair or any fracture. And know that this is a medical emergency, and the treatment is what we call a fasciotomy. So the fascia is kind of the tissue of that bag. So a fasciotomy means we need to slice open all of their tissue through the fascia to allow space for that swelling to actually swell. We need to get rid of the pressure, which means opening up the bags. This can get super gnarly for patients. So final warning, this next section is going to be pretty gross. Here is a person with pretty advanced compartment syndrome. So we can see black tissue. We can see swelling in the foot and discoloration compared to the other extremity. This is somebody who has compartment syndrome, and they need a fasciotomy, meaning we've got to open them up all the way down to the muscle and expose the muscle to relieve the pressure from inside the fascia, which is this kind of a procedure. In the lower extremity, there aren't as many bags, right? Because we just have our calves back there in a bag, so we just can do one incision and open them up like this. These are massive incisions, by the way. If it's up in the thigh, quads, 4 bags. So they're gonna have 4 incisions like this. So these patients are gonna come out of surgery after compartment syndrome with massive, massive incisions. And sometimes these incisions are gonna remain open like this for a day or two in order to let that swelling come down, in order to prevent that tissue damage inside the body. So here you can see the calf muscle, here's the Achilles tendon, bone in there. This is a gnarly, gnarly thing. We don't always just look out for these types of problems in patients like skeletal system, musculoskeletal system, so in the quads, calves, arms, forearms, things like that. Patients can also get abdominal compartment syndrome. Any part of the body that's encased in a bag can get an excessive amount of pressure from trauma and start to develop compartment syndrome. So it's always something we look out for patients that have experienced trauma or have had a fracture. Whew, that was gross. So for evaluation, things we want to look out for, make sure our patient is ready to be as independent as possible when they leave that acute care environment. So after their surgical repair or whatever repair is done to fix their fracture, can they be as independent as possible? Part of that is adaptive equipment. Our key resource and our key experts for adaptive equipment for our patients is physical therapy. They are experts in how to help patients do gross motor movements, like move whole extremities or their whole body using adaptive equipment. So they're gonna teach patients things like crutch training, which is like a big deal because anybody who's used crutches knows that these are basically catapults for injury for people. All it takes is one step down and you're like, whoo, catapult yourself off that step. So they'll teach patients how to use these types of devices. Other things, signs and symptoms of complication, this is all us. So infection, especially with our open fractures or any patient that's had surgery, high risk for infection. Compartment syndrome, especially in that immediate preoperative and postoperative phase where our inflammatory response is at its greatest. We need to make sure that they don't have any CMS compromise, so circulation, motion, sensation. So that's our circulatory assessment, musculoskeletal assessment, and our neurologic assessment of that fractured extremity. And then any blood clots, right? So this both applies to preoperatively when patients may be actively bleeding or having an inflammatory response associated with their fracture. And post-operative, if they've had any hardware left in, we want to make sure that they don't develop a blood clot. So again, doing those CMS checks will help us identify blood clots as well. That's bone fractures. Next, we're going to talk more about ORIFs and joint replacement, so specifically hip fractures.